All right, we have some endocrinology to do today. We're going to embrace my least favorite side of medicine. That's everything to do with endocrine, and yeah, we'll see how we crack on. We have a 47-year-old woman admitted to the surgical ward with severe low groin abdominal pain. A CTKB shows right-sided renal calculus. When you clerk her in, she admits to you she's not felt herself for the past few weeks. Polyuria, polydipsia, constipation, and altered mood. All right, I think we know where we're going. Looking at the calcium, calcium is high. We know that when the calcium's high, we expect the PTH to be down in the basement. But here it's loitering to the top of normal. Looks a little bit suspicious. Out of all these, we're thinking renal stones. And with that, we're thinking the classic stones, bones, groans, psychiatric overtones. She sounds like she's getting a whole collection here. Polyuria, polydipsia, probably a bit dehydrated. You'd probably stab some fluid into her for this high calcium in the first instance. Phosphate is also low. With these bloods, we know that calcium is high, phosphate is low, parathyroid hormone should be low, but it's looking normal. So we're thinking that this is really going to be the actual cause here. So going for primary hyperparathyroidism, that sounds pretty correct to me. You get this with chronic kidney disease. The calcium would normally be high, but not sky high. Secondary hyperparathyroidism, that's generally a response to chronic kidney disease. We'd expect the calcium to be low normal, not sky high. Sarcoidosis can cause high calcium via, pretty sure it's vitamin D activation, but again, we would expect PTH to be suppressed. Tertiary hyperparathyroidism, this is really long-term CKD. I don't think that's going to be likely. Type 1 RTA, no, not likely. Let's stick with this. Fine. It is normal. We might expect it to be high. That's okay. Let's go next. 35-year-old female presents to GP complaining of lump in neck. On exam, you find 2 centimeter lump midway down a trachea, palpable enlarged lymph nodes on the right side. Okay, just one lump. Don't know if it's painful. You suspect thyroid malignancy. She is sent for further imaging, which confirms this. Unfortunately, her prognosis is prognosis is considered to be excellent. Oh, that's pretty good. There's only one type of neck lump that I think is good. That's papillary carcinomas. These are by far the most common. I think like 80%. These other ones are less friendly. I think follicular adenomas are pretty benign as well. But I think the rest of these are pretty horrible. So there we go. See what we're saying down here. 70% of cases. All right, I was a bit wrong. Okay, let's go next. 37-year-old woman presents to a GP 4-month history of palpitations and headaches. She is considered that she is entering early menopause and experiencing hot flushes throughout the day. She has a past medical history of type 2 diabetes. Obs show normal heart rate, very high blood pressure, temperature, and O2 is fine. So she's got a high blood pressure. Urine dip shows leukocytes, nitrocytes negative, trace glucose, trace ketones, pH 6. What's the most appropriate investigation for this patient? All right, a 37-year-old who's hypertensive, having hot flushes. We've not actually spoken about cessation of her periods or anything like that, so I don't know if we're going to be doing LH and FSH. We might be wanting to look at this blood pressure a little bit more. So I'm not going to lie, I'm not entirely certain. I don't think this is going to be the ovaries misbehaving. I don't think it's going to be anything to do with aldosterone-renin ratio. That's mainly for some primary hyperaldosteronism. So that's some Addison's. Whereas urinary metanephrines, I always forget with the metanephrines and catecholamines which one's which, but I think this is the one for pheochromocytoma, which you might be looking at. diabetic history. Next. Most likely diagnosis. Is that right? 34-year-old woman presents GP 3-month history, lethargy, weight loss, reports no fevers or night sweats, feels unwell. Otherwise, medical history includes endometriosis, for which she takes a combined pill. Blood pressure is a little bit low, heart rate's normal, respiratory rate is normal. Lab results show normal platelets, normal HB, white blood cell normal, sodium a little bit low, potassium pretty high. Okay, so this is endocrine, some endocrine stuff going on. Addison's disease, so hyperaldosteronism is going to cause the collecting tubules to have a lot of aldosterone in, which causes potassium intake, sodium outtake. I think it's going to be that. Let's have a look. Yeah. When it's the first on the list, it's hard to even go through the other ones. Don't even read the other questions. Quite straightforward. 53-year-old man admitted to hospital with a chest infection and has a set of routine bloods done in the ED. His HbA1c is below, very borderline. Which of the following medical conditions would mean this result would overestimate his blood sugar levels? I know that sickle cell, they have very weird things about blood sugar levels. So if it was to overestimate, maybe that's due to the increase in the... Alright, so we have sickle cell. So the issue is, we know that if he has a condition, so he's a little bit borderline diabetic from these bloods, we're thinking about the turnover rate of red blood cells. And this question is asking us which of these conditions interfere with that. So we know that the spleen's generally pretty good. Red blood cells live for 120 days-ish. Spleen will sequester them. And out of all of these, if you've had a splenectomy, that would cause blood to hang around longer, I believe. Whereas the rest of these, your spleen will destroy prematurely. So I think it would underestimate HbA1c. So let's see. Splenectomy can cause false high HbA1c levels due to increased lifespan of red blood cells. All right, we're on a pretty good roll here. So next, we have a 42-year-old man presents to the ED with a headache, sweating, palpitations. All right, we're thinking something adrenaline-y. These symptoms have been going on for a while, the last hour, and he feels they're worsening. On exam, his blood sugar is found to be 180/90, fine tremor in both hands. His urine is sampled and shows high levels of metanephrines. All right, so thinking pheochromocytoma. That's an exciting one. Given this man's presentation, what's the most appropriate first-line treatment? So, if I was to see this, high blood pressure and fine tremor, I would normally think about beta blockers. However, I think from the recesses of my memory, I feel like there's a no-no about doing beta blockers in people with pheochromocytoma. I feel like it might be this instead. He's got high blood pressure, so you could throw him. I don't think wouldn't want to interrupt with one of these calcium channel blockers. He'd probably have to have surgery eventually, but I think phenoxybenzamine is the go-to first. There we are. Give it before beta blockers. All right. I think that makes sense. A 23 homeless man brought to ED, fluctuating consciousness, who's been complaining of abdo pain whilst intoxicated for a few hours prior. You're aware of previous alcohol and overdose admissions. Okay, so it's not his first rodeo. A to E is patent, resps are up, oxygenating, fine, heart rate, elevated, blood pressure a little bit low. You always get worried when heart rate is over 100 and BP systolic is under 100. Cap refill delayed, dehydrated. Sounds like he's quite unwell. Glucose is very high, ketones also very high. Do we know that is this a DKA situation? Do we know he has a history of any diabetes? We do not know. That's my most likely bet, but we don't know much about his history. He's very dry, you get that in diabetes and he's very acidotic. And bicarb is low. Okay, so bicarb is low. Oh, what's the saying, DK? Alright, another straightforward one. A 56-year-old man is reviewed in cardiology, outpatient clinic, following it 1 year previously. During his admission, he was found to be hypertensive, diabetic. He complains that he has put on 5 kilograms of weight in the last 6 months. Which of his medications might be causing this? Okay, so he's had an MI, he'll have been started on a bunch of meds. I think the most likely suspect is the glycoside. I'm pretty sure those sulfonyl cause weight gain. The other ones, less so. Let's see. Straightforward. Diabetic man is diagnosed with having a diabetic neuropathy to his feet. He has no other medical conditions of note. What is the most suitable first-line treatment to relieve his pain? Okay, so this is going to be... first-line treatment. I don't think it's any of these ones. Duloxetine is SSRI. Sodium valproate, don't think so. Carbamazepine, I think you could see it, but I feel like if it's going to be a chronic thing, he might have to start something like gabapentin or Pregab or one of those neuropathic pain agents. Oh, just so wrong. I really didn't think that duloxetine was going to be the one for this. Okay, you gotta just take the good with the bad. Duloxetine, first line treatment, and painful diabetic neuropathy. Alright. Some of the things you just don't know. We're all here to learn. Okay. And which of the following unwanted effects is most likely to occur in patients taking glycoside? We know weight gain. We've just had this question. Sulfonylureas. Okay. Alright, that's a wrap. That's our first entry into the abyss of endocrinology. It's John Pincock.